I have a patient who comes in the middle of a migraine, predominantly in the forehead, with light sensitivity, noise sensitivity. They're ready to throw up. And I give them a local anesthetic in the occipital region, which is the back of the head. And within minutes, their eyes open up, patients start smiling. And it's like, how did that happen?
Charge up your axons, ready your receptors, and shift your lobes into upper beta phase. You are listening to Smart Drug Smarts, the podcast dedicated to helping you optimize your brain with the latest breakthroughs in neuroscience, nootropics, and psychopharmacology.
Hello and welcome to Smart Drug Smarts. My name is Jesse Lawler. I am your host, and this is the 217th episode of this podcast dedicated to the proper care and feeding of your own brain, keeping it high-performing, operational, and comfortable. Today we're going to be looking at some ways that the brain's operations can go wrong, some of which are congenital, some of which are things that we pick up along the way in the course of bumps and bruises over a lifetime. We're going to be talking about epilepsy, migraines, and headaches in general. I think it's safe to say that anybody listening has had a headache at some point, but each of these is very interesting topics, interesting being somewhat of a coded way of saying that science has not got them completely figured out yet. Lots of different presumed causes, lots of different types of care that are still applied, a lot to learn, and we'll be talking with an expert in epileptology and migraines, Dr. Sid Kapoor, in the main interview. If you hang around until the very end of the episode, I'm going to tell you what scientists have recently found out about the evolution of brain shape in modern humans. But for right now, let's start things off, as usual, with This Week in Neuroscience.
Smart Drug Smarts, This Week in Neuroscience.
So if you're listening to a podcast and all of a sudden the audio craps out in one of your earbuds, it is decidedly better if it's the left earbud that goes out and you're still able to hear out of your right ear, because right ears in most people tend to be better for speech processing. Insert here the standard caveats about right-handed people and left-handed people being different in their average brain lateralization. But it has been known for a long time that children tend to understand and remember better verbal information presented to them that they can hear through their right ear. Sounds entering the right ear are processed by the left side of the brain, which controls speech, language development, and some types of memory in most people. And to learn this, to look at these differences, what researchers have done is what's called a standard dichotic test, in which listeners receive different audio inputs delivered to each ear, all played at the same time. This might be a series of numbers or letters or actual full sentences. The research participants are asked to either pay attention to only one ear, like listening with your left ear, ignore your right ear, or vice versa. That's called a separation test, and the other is called an integration test, in which case you've got information coming in from both sides and you're trying to remember and repeat everything. And as mentioned, young children's auditory systems are not very good at this. They can't sort and separate simultaneous information coming in from both ears, and they tend to favor the right ear for these tasks, says researcher Aurora Weaver from Auburn University. Conventional research shows that this right ear advantage diminishes at around age 13, but our results indicate that this is related to the demand of the task. They had 41 participants in the age ranges of 19 to 28 years old complete both dichotic separation and integration listening tasks, and they found that there was no particular difference in right ear and left ear performance as long as the number of things that the person was being asked to remember was less than their simple memory limit. This is the typically 5 to 9 pieces of information that a person can hold in short-term memory at one time. But once the amount of information that was coming in this listening task was beyond that limit, suddenly they started seeing better performance again coming from the right ear. This was an average improvement in accuracy of about 8%, but for some individuals as high as a 40% difference in favor of the right ear, which seems to imply that we're naturally better at processing this information with the right ear left brain. As we age, the brain figures out how to do it equally well in normal situations with both ears, with a standard amount of information that would be in short-term memory. But just beyond that point, the right ear advantage is still lurking. This research was presented last year at the annual meeting of the Acoustical Society of America, where researcher Danielle Sacchinelli said, "The more we know about listening in demanding environments and listening effort in general, the better diagnostic tools, auditory management, including hearing aids, and auditory training will become."
Smart Drug Smarts, the podcast so smart, we have smart in our title, twice.
Picked up a couple of 5-star reviews on iTunes. Listener Squiggums from the USA said, "I have survived 4 heart attacks 7 years ago, and I need all the information that this podcast has." And listener Jared Burnt from Australia says, "Hi, mate. Myself and colleagues love your podcast. Great info and a great variety of guests. Well, thank you, Jared. Thank you, Squigums. And thanks to everyone who's left an iTunes review or otherwise helped promulgate Smart Drug Smarts out there into the wider world. As I've mentioned, for the past couple of weeks, we're doing a final sell-down sale of our remaining supply of Nexus over at axonlabs.io. Been doing a daily price drop every day at 7 a.m. Pacific time. Currently more than 25% off what has always been the base price, and continuing to drop so long as there is any supply remaining. I'm told both that there's a little bit left and that there is not very much left. The best way to know for sure is to head over to axonlabs.io and see if the sale page for Nexus is still letting you add things to the cart. Here for the long term, not going anywhere, is Vitamonk.com, which I think when we first introduced Vitamonk last year, they had a few more than 20, maybe 25 different products. They're now up to almost 40 different supplements, something for almost every occasion, from Alpha GPC and Ashwagandha to their VibraJoint stack for joint health. Not quite A to Z for their supplement line, but A to V with a lot in between. We'll probably start cherry-picking some of their brain-relevant supplements to zero in on in future episodes, but for right now, you can check out what they've got at Vitamonk.com.
Smart Drug Smarts.
So I'm about to be speaking with Dr. Sid Kapoor from the Kentucky Neuroscience Institute. He is an assistant professor of neurology at the University of Kentucky College of Medicine, as well as being director of their headache medicine division and director of their epilepsy network. Epilepsy and headaches are two things that we don't necessarily think about in tandem, but as you might imagine, based on the fact that we're having an episode putting both of these topics together, there is some overlap, as we will hear, especially potentially in treatment methodologies. Headaches affect pretty much everyone from time to time. Migraines less of us, but still a substantial portion of the population. And epilepsy, while relatively rare, is definitely not all that rare, maybe not as rare as you'd think. All three of these conditions provide interesting windows into the brain, understanding how things work and what causes things to go wrong sometimes. The interview that follows, as you will hear, is kind of divided almost down the middle. The first half, we're talking largely about epilepsy. The second half, we're talking largely about migraines and headaches. So if you're more interested in the headaches, you can skip ahead, but recognize that the first half does lay a lot of groundwork that we refer to later. So get yourself hydrated, put on a helmet if that seems like a good idea, and let's talk epilepsy, migraines, and headaches with Dr. Sid Kapoor.
My first exposure to epilepsy actually started at a very young age. I was hardly 10 years old, playing card game with my uncle over the summer break. And I saw him have a convulsion, and then there was a whole reaction trying to hide, and there was this whole scene that erupted as if I had seen something bad, and it left a very deep impression on me. And after I went to medical school, and I was always attracted to neurology and just followed my interest and kept on learning more and more about neurology, epilepsy, I realized that there was a lot of fear that was out there, and I thought knowledge was the way to address the fear. If everybody's running scared away, then there is maybe something I can do, I can learn and be more empowered to address that head on instead of joining everybody else and running away from it. So frequently, I found myself to be the only person who was willing to jump in and take care of a complicated patient with seizures or epilepsy when others wanted to avoid the situation. And here I am. It's just been a natural flow, following what I really wanted to do.
Are epileptic seizures typically correlated with other problems that a person might have physically, or do they show up sometimes just in the absence of other problems?
So epileptic seizures occur because of their manifestation of epilepsy, and epilepsy is very rarely alone. It can happen alone, but what we would say is there is a significant comorbidity, and that we need to address that comorbidity in the same person who suffers with seizures. The most common, I would say, is mood disorder, typically depression. But in addition to that, there are headaches. Of course, many patients have an intellectual disability, depending upon the type of epilepsy. When we talk about the epilepsy syndromes, there are multiple epilepsy syndrome, and all patients in my clinic on the same day may all be different. They may have seizures starting in one side of the brain. They may be genetic. It may be related to a structural cause. It may be traumatic in origin. So the cause of epilepsy is also very different. The epilepsy syndrome is different, and then the seizures that are associated with the epilepsy are different for individuals.
I think that a lot of us forget that just because you've never had a seizure before doesn't mean that there's not a seizure in your future. With the right or with the wrong sort of brain injury, everyone is a potential seizure candidate.
Seizures typically are seen as a delayed consequence of brain injury, typically more moderate to severe. I would say the motor vehicle accident in the civilian population and some of the battle injuries that we see in our veteran population in the soldiers returning from the wars is a more common cause of epilepsy, post-traumatic epilepsy. Fortunately, closed head injury or very mild traumatic brain injury, more commonly associated, or the bigger symptom that we see with that is disabling headaches rather than seizures. So in a traumatic brain injury spectrum, the more severe the injury is, the more likely you're going to shift towards an epilepsy spectrum.
And how should we think about this as regards the motor cortex of the brain? If it's the motor cortex that's experiencing an epileptic seizure, the results are going to be obviously much more visible, I guess, to the outside world. But do seizures also affect other parts of the brain? Could there be something which would be analogous to a seizure that doesn't touch the motor cortex?
That's actually a great question. One way to understand is that the seizure is a spreading electrical discharge. It's an abnormal synchronous electrical discharge that is traveling, or in some cases in focal onset seizures that are spreading. It starts in a part of the brain and then spreads to the other areas. So it can start in a very silent area and have absolutely no symptom. But it can start in the emotional areas, or what we would say the limbic system, and can have psychic symptoms. There is typically an early warning sign, which patients will refer to as an aura. But that is the early involvement of the symptomatic zone. The motor component of the seizure will come when the motor structures are involved. Sometimes it's the basal ganglia, sometimes it's into the motor cortex, but that may be a spread pattern. The seizures may start from one place, but may end up in a different place, and some occasionally will spread to both sides of the brain, which is what we see as a convulsion. When we do research in seizures, we typically then stratify and actually make a distinction between what we call as partial seizure or a focal seizure with observable components or without observable components. So a person who has a seizure that is limited only to the sensory areas may have a lot of subjective sensation that a trained observer like me, I would not be able to see anything with the patient. However, the patient may be having a symptom. However, there are seizures, if there's a motor component to it, that would be an observable component. If there is loss of awareness, if there is loss of consciousness, then that would be something that I could test from the outside while talking to the patient. So seizures can have what I would say an observable component, or they maybe completely lack an observable component, in which case they're not associated with loss of awareness, but they can be epileptic phenomenon.
How do people verbally describe this sensation of aura, of non-physical seizure?
It is fascinating, and that is one thing which makes my work so interesting. I love that part of being a physician who takes care of patients with epilepsy. When patients come and tell me about their auras, it can be so varied, and not all auras are unpleasant. Most of them are. There are some which are very stereotypical, typically, something burning rubber, a metallic taste in their mouth. So there can be varied phenomenon that happen. Most of the times it's an unpleasant sensation. Sometimes I have heard about people experiencing auras that are very pleasurable. So I once had a patient whose sensation prior to the seizure was of a perfume, and he wanted to get rid of his seizures, but not the very wonderful smell that he got before the seizure.
Can I keep the good part?
Yes, he wanted to keep the good part. So again, it can be as varied as the patient. Many times patients don't remember. Frequently we have this experience where patients will deny ever having an aura. They just don't remember, because the seizure can also result in a memory loss for a few minutes before the seizure starts. And then we bring them to the epilepsy monitoring unit and we give them a button to press when they feel the seizure coming on. And there they are pressing the button. So they have an awareness. They will alert the medical staff. However, they don't remember what exactly they had.
Are the areas in the brainstem that are involved in really basic mission-critical biological stuff, things like heartbeat, are they somehow insulated or protected against epilepsy in a way that other areas aren't? It seems like if you had the equivalent of an epileptic seizure and it affected your heartbeat, you'd basically go into a heart attack every time.
That is an area of research, and there is a phenomenon which we call as SUDEP, or SUDEP. It stands for sudden, unexplained, and unexpected death in epilepsy, which is the occurrence of death, typically thought to be related to a seizure that happens while the patient is asleep. It is correlated with a higher number of convulsions that happens typically in young males. We don't have a very good explanation for why this happens. Nothing is confirmed because, again, as I said, it's unexpected and unexplained to a certain degree. But the idea is that after a seizure, some initial research suggests that there is suppression or there is a loss of the normal recovery of the brain that should happen. So normally a person has a seizure and then they recover. But when the recovery process doesn't work as planned or doesn't go as planned, and there is suppression of the cardiorespiratory drive and return to normalcy, is what the thought is that it might at some point be leading to permanent loss of oxygen and hypoxemia and hypotension and resulting in then death. So that is what we think happens when people do die as a result of a seizure, typically in the post-ictal phase, because the recovery does not happen. So yes, there is protection, but again, that protection always doesn't work, and that has very, very unfortunate consequences.
And how prevalent within the population is epilepsy? How many people deal with this?
So we think that the prevalence can go anywhere from 1% to 2%. If you're going to a big classroom, you're probably sitting with somebody who has had seizures and has epilepsy. There is a variation depending upon, of course, age and how homogeneous the population is, different factors. There's a stroke belt in the US, which is a consequence of the diet and exercise patterns and obesity. And stroke survivors also have a significantly increased risk of seizures because stroke results in brain injury.
Right.
We do a fabulous job, thanks to our stroke colleagues and all the wonderful development of thrombolytics and all the advances in stroke, that we are saving a lot of lives. But a lot of these patients, they survive, but they survive with consequences, one of which is epilepsy. That also leads to an increased prevalence, especially in the elderly population. Stroke and, again, cancers, metastatic disease, tumors remains a leading cause of epilepsy in the elderly.
And for younger people dealing with epilepsy, this is also a heritable condition. It's something that passes in families.
Of course, we discover genes every day, and many of the epilepsies are genetically driven or inherited, especially the childhood epilepsies for the younger people. Some of the genes have been very well identified. They're associated with very well-defined epilepsy syndromes. NIH and other organizations have invested a lot of resources in trying to figure out the etiology of inherited epilepsies. And I think we will learn a lot. It is amazing how much we have learned over the last few decades. It's an ever-exploding field of epilepsy genetics.
And I know that there's a lot of different ways that have been tried over the years, many of which are still in use to try to remove or alleviate the effects of epilepsy. Extreme high-fat ketogenic diets are one thing we've talked about in some previous episodes, and also implantable deep brain stimulation devices that monitor for the oncoming electrical storm of an epileptic seizure. And famously, split brain patients, although that isn't really done anymore. But what's sort of available now for dealing with this problem?
There are different approaches. Of course, medications always remains the first go-to for any person with epilepsy who's suffering with seizures. And the important concept to recognize there is the idea of refractory epilepsy. So research over multiple decades, multiple times with different time periods in history has demonstrated that most seizures, approximately 47% of patients will respond to the first drug that they are given. Another 13% will respond to the second drug that they are given, and another 4% will respond to the third medication or anti-epileptic drug that they are given. So in overall summary, the majority of patients will respond to 3 medications or less. But there is a segment of the population, approximately 36%, that will not respond to, the 3 medications at a good dose that has been tried and is suitable for their kind of epilepsy. For this 36%, I would say quite a significant number of patients can actually benefit from epilepsy surgery. So if they have what's called as focal epilepsy, where they have an area of the brain which is resulting in the seizures, trying to identify that area. And if that area can be safely be removed, then there is very good evidence to suggest that that is the correct way to treat the patient. It is the best chance at what we would call a cure. And again, approximately 70% of patients with the right kind of surgery can yield very good results and on a long-term basis. Some patients, however, are not candidates. They may have more than one area where the seizures may be starting from. Some patients may have eloquent brain function, or the structure may be very deep, or the network that results in the seizures might be a little bit more widespread, and it's not easy to disrupt the network without harming a very important function that may affect the patient's life. So in that case, you go with what we would call as palliative options. None of them is going to typically result in a cure, but they definitely help the patient. So medical devices can be utilized. One of the most well-known for the longest time has been the vagus nerve stimulator. And besides the vagus nerve stimulator, the responsive neurostimulation, which you alluded to earlier, is one of the devices that can be utilized and is quite effective, for the right patient. And we are finding more and more role for it as number of patients who have gone through it, and they're coming back, and we see the benefit that our patients are getting from the device. I believe it's almost about 1,000 patients in the U.S. that have now received the responsive neurostimulation.
And so we've been talking about epilepsy to this point, but you are a headache specialist, a migraine specialist, as well as an epileptologist. Can you tell me about how those conditions overlap, or how the populations that are affected overlap?
So I trained as an epileptologist, and how I got interested in headache was that as a practicing neurologist, patients don't come to a physician and say with clarity that they have seizures. As I said, we were discussing earlier that the symptom and the warning sign of an aura can be very subtle. It can depend upon where the activity starts. So when a patient starts talking about their symptoms, about the episode that they're having, and with a recollection that is sometimes limited by their memory of the event, how much they actually remember, we also go with objective accounts, what the family tells us. So patients will come and they'll report events and episodes of neurological symptoms over an extended duration. And it is the job of a clinician to figure out whether is it a seizure, is it a migraine episode, is it a stroke-like episode. So over the years, what I found myself was dealing more and more with paroxysmal events, paroxysmal neurological symptoms. And the more we delve into what the differential diagnosis or what the different possibilities are, you have a very wide variety. So not everything that looks like a seizure always ends up being an electrographic or an electrical seizure that can be traced to the brain. Patients who have seizures, approximately almost 40% of them after the seizure will report a really bad headache. It is actually disruptive to their life. I have a patient who is very clear. He says, my seizure lasts 3 minutes, but the headache that happens, it destroys me. I can't function. I have to go home and sleep it off. That is what is disrupting my life.
Yeah.
So again, the overlap between headaches and seizures is very high. For the longest time, there was really no drug that was available to treat patients with migraine. So neurologists who are very comfortable with using medications and anti-epileptic drugs started testing and utilizing these medications to prevent migraine headaches. Over time, it became just convention to use them. There have been trials now to prove that many of the anti-epileptic drugs like topiramate and valproate have been effective. And in fact, topiramate is FDA approved for preventing migraine headaches. But these drugs were not designed for migraine. They were designed to treat epilepsy. So there is a significant overlap between what we think happens in the brain and can result in different phenomena.
Could we actually go ahead and define migraine versus headache? I personally have never had a migraine, so in my imagination, a migraine is just a really, really bad headache. But is there more to it than that, medically speaking?
So it's a dual definition. One of the most common causes of headache, and approximately 36 million Americans have migraine headaches. Now, I would not like to minimize the suffering of a person with migraine to say that headache is the only symptom that they have, but in a continuum of symptoms, a moderate to severe intensity headache is probably the leading symptom, typically associated with light sensitivity, noise sensitivity, nausea, vomiting. In the classic definition, it's approximately a 4 to 72 hour long headache that may affect half or the whole head. But people with migraine suffer with a lot of different symptoms, but headache is a significant portion that results in disability for a person with migraine. But there are non-migraine headaches as well. So very broadly, when people talk about headache, everybody worries about brain tumor. That is actually less common, though the vast majority of patients who are having headaches and have completely normal MRIs don't have another cause for having their headaches. They don't have infections, meningitis, or epilepsy, or any of the secondary causes. If they have an underlying, typically a genetic vulnerability, or if they have migraine headache, which is a syndrome in itself, then that is one of the most common causes of headaches. Frequently, patients with migraine have a higher prevalence of seizures, and patients with epilepsy have a higher prevalence of migraine headaches. So while these two conditions exist independent of each other, they do seem to overlap in populations as well. If you talk to people who have had a seizure, after the seizure, one of the most common types of headache when they describe maybe as short as a 5-minute headache. Many of them are fortunate not to have a headache, but when they do have a headache, one of the most common descriptions that we'll get from them is that it mimics migraine headache. It also responds multiple times, typically to a migraine medication as well. But what we don't know is, and this is an interesting question, is if I see a patient with both conditions, is there one medication? I can talk about topiramate as being one medication which is approved for both. And it would be a simple for me to say, well, I would only use topiramate, but that possibility doesn't exist for a lot of my patients. So do we know which drug is better, or if one drug is typically better for patients who have both? And what is very interesting is that there are some anti-seizure medications which seem to actually worsen headaches as well. So it's not a simple relationship where we can assume that treating one condition will always result in improvement in the other condition, which makes the job very hard. And I hope that we can answer this question over the next years.
Here's one more thing that I've always found confusing is, the brain itself famously has no nerve endings in it. A neurologist who has an open human skull can poke the brain and the person doesn't feel anything. So when somebody feels a headache, which nerves are actually being triggered there? Where is that pain coming from?
Again, a fascinating question, and I think our neuroanatomy and neuroscience is changing. Some of these ideas were old, and I think there has been some evolution in what we now believe. We are finding new things, which I don't think we have tied the whole loop and we can explain everything. If you approach it from the migraine side, initially the idea was that it was a vascular headache. Then we sort of went away from that idea and we figured out that the critical pathway was the trigeminal vascular system.
It's a nerve that goes up through the jaw, right?
Correct. And we have now found that the trigeminal is the innervation of the head and neck region, very broadly speaking. The vast majority of the sinuses, the forehead, the face is innervated and supplied through the trigeminal nerve or its branches. And pain that may start in the brainstem, the pain that may be starting somewhere else, is then referred or is perceived to be in the head or face region. So over the past few years, one of the interesting things has been the emergence of what I would call an occipital nerve block to be utilized for treatment of a migraine headache. So here you have a situation where, I have a patient who comes in the middle of a migraine, having a headache that is predominantly in the forehead or even behind the eye with light sensitivity, noise sensitivity. They're ready to throw up, can't take any medications. And I give them a local anesthetic like lidocaine or bupivacaine in a small amount in the occipital region, which is the back of the head. And within minutes, their headache starts getting some relief. Their eyes open up. They are no longer light sensitive. patients start smiling. And it's like, how did that happen? That giving a local anesthetic at the back of the head produces this dramatic relief in some cases as early as 5 minutes, even before the patients walked out of our room. We have been doing this more and more, and it's, there's increasing evidence behind it, and we are targeting different areas. Sometimes we do a forehead injection, sometimes we do an injection targeting the sphenopalatine ganglion through the nose. So again, we are trying these different nerve blocks, and the unifying idea is through the occipital nerves as well and through the cervical pathways, there is a spinal nucleus of the trigeminal nerve. And the local anesthetic, we think, is being picked up by the trigeminal vascular system, and it is stopping that feedback loop and bringing relief to the patient. So it is fascinating. Then there is the glymphatic system, which was very recently discovered. And do we think that that has a role to play with headaches? We think so. Have we proven any connection? No, not really. Again, headaches are extremely broad. Sometimes, they have an identifiable cause. Sometimes they don't. So it is interesting in that way.
That seems potentially really promising, that approach of dealing with a local anesthetic to some part of the body that really does have pain sensory nerves. Is there any way that it would be something other than that? Does there have to be some misperception of pain signaling from some other part of the body to account for what we perceive as headaches?
It's a tough question, but the areas that we typically target, and I think having been a neurologist for 20 years and having done nerve blocks for the last 10 plus years, the question is, why didn't we think about it earlier? That was not the way when I trained. We were not typically being taught it this way. And, why were we not using local anesthetics to relieve head pain? It was such an obvious thing, but it eluded us. So occipital region is one, and then of course the trigeminal branches is another. The sphenopalatine ganglion is definitely a target, and we have not only local anesthetics, but there have been trials with peripheral nerve stimulators. They have been a little bit more disappointing in outcomes and not really FDA approved, more because of complications and not the best efficacy. I don't think we have figured the stimulation paradigms out very well. But in the short term, all of these are good targets. The general consensus, I think, among my peers that when I talk to is that trying to produce numbness or hyposthesia in the area of the pain usually brings about the best outcome. So, the occipital region, it allows us to administer the highest volume of the drug. So it's very commonly used. But if the pain is predominantly in the forehead, then trying to achieve numbness in the forehead or trying to do a trigeminal branch block might be more beneficial for the patient or has a better outcome than just trying to do an occipital nerve block. So, we do an occipital nerve block plus approach.
Is there really any downside to having limited local anesthetic if that was something that somebody had to apply regularly because they get migraines regularly and they found out, hey, if I hit this one specific spot behind my ear, then that solves the problem? I mean, if somebody was doing that a couple times a week, would there be a long-term downside?
I think the biggest hurdle is that, it's hard to inject the back of your neck, or it's hard to do a self-administration. We don't really recommend that. I think the long term is, again, this is the one time when I'm trying to strike a nerve. So there is a chance that I may actually cause injury to the nerve, and there may be permanent numbness. There is, again, a hypothetical risk that the nerve may actually flare up and cause more pain while doing the injection. Thankfully, it's not happened, but I can't give a guarantee that that may never, ever happen for a rare patient. And then, nerves and blood vessels run together. So there is always the accidental risk of intravascular injection, meaning that we are trying to push the local anesthetic into the nerve, but it ends up going into the blood vessel.
Right.
And then going to the heart. And, that can cause patients to pass out till they clear the drug. Again, it's a function of trying to stop that feedback cycle from happening. But one of the ideas itself is that if we do end up causing a long-term nerve damage, assuming it doesn't flare up the pain, that actually might help the patient. What I find is we do these nerve blocks on a repeated basis. There is a limit to how many I'm able to do for the patient. And after a certain point, I think to have a more long-lasting effect, I'll typically send the patient to my pain colleagues who can go under fluoroscopy under direct imaging, in this upper cervical part of the neck and they can do what's called a radiofrequency ablation, where they will actually use heat to typically do a neurolysis or cause more permanent destruction of the nerve to stop that feedback cycle. And a lot of patients will benefit. There is not a 1:1 correlation that if you've been benefited by the nerve block that you are always a candidate for a radiofrequency ablation. But selecting those patients, and many of those patients will tremendously benefit from their headaches. Now, some of those patients have a trigger. They may have a neck trigger. They may have, a condition called occipital neuralgia, which is then feeding their migraine headache as well. Sometimes it's very difficult to tease out the two conditions when they might coexist in the same person.
You've mentioned how over the course of a lifetime, people are more and more likely with advancing age to experience epilepsy, whether that's from repeated knocks on the head or whatever else. Does the same trend hold true with migraines and headaches, where the older you are, the more likely you are to experience these?
Fortunately not. The prevalence of migraine is heavily influenced by the sex hormones. So, you can typically think about it as a disease that predominantly and unfortunately affects women during their reproductive years. Not that that is all the patient. It can start in childhood. We have taken care of patients as early as 3 to 4 years, and it can have very different and very difficult to diagnose presentations in children. An equal number of boys and girls will have migraine headaches till they hit puberty. And then after puberty, girls and women will outnumber the boys and men till menopause. And after menopause, again, it sort of levels off, and a lot of women will get some relief. A lot of women will have very disabling migraine headaches in association with their cycles. So there is a significant hormonal influence and a very significant burden on women.
What are you most interested in seeing done as far as current research or maybe near future research looking at these topics?
So my personal interest is, again, the overlap between headaches and epilepsy. And what I would like to see is better definition, better understanding of what causes these overlaps. What can we do to differentiate the two? The future is of personalized medicine. The future is not to have, 15 drugs and just throw the kitchen sink at the patients. It's to tailor the therapy according to what the patient needs. I think we do a better job today than we ever did about tailoring that therapy for the patient's particular constellation and combination of symptoms. And I think if we can have a better understanding of how exactly to treat, either utilizing their genetic makeup, either utilizing their symptoms, their triggers, the hormonal influence. The hormonal influence is there even for seizures. So what can we do that we could manipulate and help the patient without causing undue harm or without causing adverse events? Ultimately, as a clinician, the idea is to help as many patients as I can. And clinically, how do we have a better idea about what to do next rather than just guessing? And a lot of it is art. A lot of it is subtle cues that, I see a lot of these patients because it's my personal interest, and I just learned that this might work better for this. That's what research does. It illuminates us. It tells us that our perceptions are not reality. And when we start looking at the data, a lot of things which we think are obvious don't make any sense. So I would like my ideas to be guided by actual data and build on systematic research rather than just perception of this might or may work. Over the years, we have had many, many missteps. We've believed that things will work only to find out that they don't. So we have to approach this with very cautious optimism.
Smart Drug Smarts.
So a big thank you to Dr. Sid Kapoor for taking the time for that interview and for putting so much work towards what is just undeniably an amazing public service. There are a few things as uncontroversially helpful and good for the human species as alleviating headaches and migraines and epilepsy. You heard him talk in that interview about the trigeminal nerve. A bit of a flashback there to episode number 112 of this show, where we talked about the surprising overlap between orthodontics and neurology. That's the first time I think I'd heard the term trigeminal nerve, but a really interesting episode to go back and catch if you haven't heard that one previously. And also just fascinating the idea that local anesthetic applied outside the brain might be a reliable way of dealing with headaches that feel, at least, like they are inside the brain. As Dr. Kapoor pointed out, that's one of those findings that scientists could have made a long time ago. Didn't really rely on any recent breakthroughs of modern technology to make that observation. Sometimes all it takes is a good epiphany, but sometimes those epiphanies don't show up as soon as they might. What else are we going to be forehead slapping ourselves about a decade from now? But let's leave headaches behind us now and start talking about very old skulls and some surprisingly modern ones in the Ruthless Listener Retention Gimmick.
Smart Drug Smarts, Ruthless Listener Retention Gimmick.
So if you spend a lot of time hanging out in evolutionary history museums, or if you pay particularly good attention at Halloween time where there's a lot of fake human skulls around, you're already probably pretty familiar with the brain case area of the human skull. And as you start looking further back down the evolutionary chain to our ancient ancestors, one thing that you'll notice is that the brain case tends to get longer and narrower than the big bulbous brains that we have now as Homo sapiens. Believe it or not, the common name for this nowadays is our globular brain shape. Doesn't sound particularly photogenic, but globular is where we're at. And even going back as far as 300,000 years ago, it seems that the human line had already maxed out, or at least reached our present proportions as far as total brain volume. If anybody asks you what your total endocranial volume is, you can tell them that on average, as an adult human, you've probably got 1,400 milliliters of brain. And this number hasn't changed in a long, long time, and in fact precedes behaviorally modern humans. However, the shape of the brain, both the overall shape and the particular contours of the ridges and bumps and folds on the brain surface, that's continued changing quite a bit up into fairly recent times, evolutionarily speaking. And according to recent research at the Max Planck Institute for Evolutionary Anthropology in Germany, it's only in skulls younger than 35,000 years of age where the brain seems to be indistinguishable shape-wise from that of a modern human. As for what changes were happening during this quarter-million-year period, the two standout changes were parietal and cerebellar bulging. As for what we can infer from these changes, the parietal brain areas are now involved in orientation, attention, perception of stimuli, sensory motor transformations underlying planning, visuospatial integration, imagery, self-awareness, working and long-term memory, numerical processing, and tool use. So almost everything in the kitchen sink neurologically. And the cerebellum has motor-related functions like the coordination of physical movements with balance, but also deals with spatial processing, working memory, language, social cognition, and the processing of positive and negative emotions. So quite a lot going on in those regions, but you'll notice not a lot of low-level stuff like maintenance of heartbeat and breathing rate, things like that. Now, lest we forget, when human babies are born, there's that soft spot in the top of the head where the skull hasn't fused all the way shut, which makes some of us very uncomfortable when handling newborns. But it's actually during the development period of the brain that takes place following birth where this globular brain shape that we now have really reveals itself. The implication being that one of the changes that's taken place to lead to our modern brain shape has primarily to do with what happens during early brain development. Says researcher Philip Goons, the evolution of endocranial shape within Homo sapiens suggests evolutionary changes in the young brain. Jean-Jacques Hublin, who co-authored the study, adds, the gradual evolution of modern human brain shape seems to parallel the gradual emergence of behavioral modernity as seen from the archaeological record. This research was based on computer modeling of endocranial brain shape based on 20 skulls from human ancestors over different time periods and was published in the journal Science Advances.
Smart Drug Smarts, the podcast that thinks too smart for your own good is really just a figure of speech.
Okay, so that's it for episode number 217. Thank you for hanging around until the very end. If you enjoyed this episode, you can find everything that we talked about here up online at smartdrugsmarts.com/217. And if you missed last week's episode, in number 216, I spoke with Dr. Psyche Louie about music and creativity. And next week will be our last episode before Valentine's Day. Got something a little bit Valentine's related with love and the brain. You guys know I'm a sucker for brain-related holidays, but I will see you back here for that next Friday. Same time, same podcast, and with that same unflagging commitment to helping you fine-tune the performance of your own brain. Have a great week in the meantime, and of course, stay smart.
You've been listening to the Smart Drug Smarts podcast. Visit us online at www.smartdrugsmarts.com and subscribe to our mailing list to keep your neurons buzzing with the latest in brain optimization. Smart Drug Smarts should be listened to for entertainment purposes only. Although some guests on the show are medical doctors, most are not. And the host is just some random guy. Nothing you hear on this podcast or read at smartdrugsmarts.com should be considered medical advice. Consult your doctor and use some damn common sense before doing anything you think might have a lasting impact on your brain.